To see so many familiar faces in what will be a fourth meeting in a series that we're having on population health and fragility, one that has allowed us to really engage in some topics that our primary audience for this discussion, the USAID Office of Population Reproductive Health and Global Health more broadly, has had some folks working on it very intensely, some folks interested and but having a lot of other things to have to work on, and then some folks really coming to this topic for the first time. So we're trying to have discussions that are interesting and stimulating for all of you, no matter where you're from to this topic. And we're thrilled today to have a terrifically distinguished group to address health provision in fragile settings, a stabilizing force. Before I do a very quick intro of our speakers, because you all have the longer bios in front of you, I just want to say a word about the center, and apologies to those of you who've heard this before. But the center is the formal memorial to Wilson. We're a nonpartisan, non-advocacy institution to bring the worlds of scholarship and practice together. And in some ways, we're doing that with the backgrounds of our panelists here, as well as our audience members. The Environmental Change and Security Program is an 11-year-old, 12-year-old program that tries to bring the specific worlds of environment, population, health, development together with foreign and security policy. And obviously questions of fragility and questions of stability of countries fall right in the purview of what we're working on. So we're thrilled to again be putting on this meeting with the support of Office of Population and Reproductive Health, and particularly Heather Diagnos and Ritu Singh, who've been our partners in this particular series. We're thrilled they're able to join us today. So a word about our speakers, and then we'll turn the floor over to Ron Waldman, who's a professor of clinical population and family health at the Mailman School of Public Health at Columbia University, someone I think is very well known to AID because he's worked with you an awful lot. He's had experiences at the World Health Organization, CDC. I think quite interestingly, a project that perhaps here in Washington we haven't appreciated enough of all the kind of intellectual brain power that went into the UN Millennium Project, and he was the lead author of the Child Health and Maternal Health Task Force report for that. A broad-ranging report that's really trying to do the research to figure out how we achieve the Millennium Development Goals. Again, a political frame that doesn't necessarily sell as well in Washington as it does at other parts of the world, but the other parts of the world are really using this frame. And so it's terrifically important research, and I urge you to seek out his paper and his papers, understated, his very weighty report, as well as the others there. And then particularly given the topic that we're talking about today, the fact that Ron has been recently working in DRC, Southern Sudan, and Afghanistan makes his comments today particularly relevant to some of the hot spots that we're talking about health provision in unstable areas. Liz McBride, to Ron's right, is working with the International Rescue Committee. Actually, both Emmanuel and Liz are. She's currently the director for the Post-Conflict Development Initiative, where she's defining policies and strategies for transitional work in fragile states. It's a humanitarian aid agency supporting refugees and communities impacted by violent conflict. She's been the country director and the deputy director for Rwanda, and again, particularly with an Africa focus, has a lot of on-the-ground experience, particularly from the conflict side. And what we've tried to do with this series and in this panel in particular is have folks coming from the health side, folks coming from the conflict side, so we can understand how each community is seeing it and engage in dialogue between them. And then finally, Manuel de Harcourt is the Senior Child Survival Technical Advisor for IRC. Again, a lot of experience in sub-Saharan Africa, including spending quite a bit of time in Senegal and Rwanda. And so we're thrilled that the three of them can join us for this discussion. Just as a reminder for those of you who have been here before, and to tell you, those of you who are new, all of the video, the PowerPoints, and summary of presentations from the whole series, as well as kind of affiliated interesting documents, are on a password-protected website, in the sense that this is in many ways an internal discussion. But there are sheets out front as to how you get to that, and we urge you to take advantage of that. If you've missed earlier sessions, I'm not suggesting you sit there and stare at your screen for the hour and a half, but open it up and listen to it as you're doing something else, and I think you'll find some of the discussion quite stimulating. So I'm going to turn the floor over first to Ron, and then I think Emmanuel and Liz, and we'll go on down the line. Do the shuffle, a quick shuffle.
So my first action is to move. because I need to have the slides in front of me so that I make sure that what I'm talking about is what you're seeing, which isn't guaranteed in any other way. I think a lot of you have seen at least parts of the presentation I'm going to make today, maybe in a more expanded version. It's my role to kind of lay out the context of what we're talking about this afternoon. It's really a pleasure to be here and have been invited. And I've been at events at the Wilson Center before, but not speaking here, so I really appreciate your invitation. Thank you very much. I think that inevitably, although we are talking about fragile states writ large, I think that, at least in my experience, and I can't speak for Emmanuel or Liz, but I think we're going to sort of lean more towards the post-conflict fragile states rather than the other categories. A lot of what I have to say today is based on, takes as its basis a study, a nationwide survey of mortality that was done by the International Rescue Committee in Democratic Republic of Congo a few years ago and was published in The Lancet in January of this year. And put simply, I think I've put it up as a 2x2 table as they report it, and it's fairly simple to see that rather than classifying causes of death, both crude mortality or deaths in the entire population and child mortality, according to specific diseases that might have contributed to those deaths, they divide mortality into two different kinds of health zones, those in which violent events had been reported and those in which there was no violence. Not that violence was a cause of death in any way. Deaths were still due to the usual causes of death, malaria, measles, pneumonia, diarrhea, malnutrition. But you can see that the contribution that living in an area where there is violence makes to mortality. It doubles the mortality rates in both the entire population and among children. So a lot of what I have to say builds upon this presumption that in fact violence is a major risk factor for increasing morbidity and mortality rates, and those of us working in public health have an obligation professionally to work towards reducing the major risk factors, of which I am contending here that violence is one. This kind of is not. Is this what I sent you? I guess. I thought what I wanted to do was to present you with a different categorization of fragile states today. I'm having trouble with my computer, and I must have sent the wrong presentation over, although I only changed a few things, so it doesn't matter so much. But just to tell you that I wanted to define fragile states a little bit differently today to expose you to something else. And in Europe, they use a little bit different classification, and they talk more about states that I'm going to concentrate on today that are called weak states. That is, they're weak in their ability to effectively deliver services to their populations, and they're weak in their desire to do so as well. So following up, and those are the countries we're going to be concentrating on. The authors of the IRC mortality survey that I just showed, Ben Coughlin, Rick Brennan, and their local colleagues, in their conclusion, write simply that reductions in crude mortality are closely associated with reductions in violence, and furthermore, that these trends provide compelling evidence that improvements in security represent the most effective means to reduce excess mortality. A lot of us who work in public health and who have done our careers in public health may find this a little bit unusual in the sense that we're in the habit of considering the most effective means to reduce excess mortality to be bringing vaccination programs to people, or bringing oral rehydration therapy to people, or bringing other disease-specific control programs to populations. So this talk is not about delivering health services to populations living in fragile states, but rather about health sector programming in fragile states, which is a little bit different. My colleagues at CDC, Mike Toole, Steve Galson, and Bill Brady, wrote a paper a while ago in the midst of the Bosnian conflict titled "War and Public Health Are Incompatible," and I think that was kind of the first time that this was raised in the consciousness of public health people. So you should all be familiar with the former USAID Fragile State Strategy. This was done before the big shift, so it's changed a little bit, but I think it still remains valid in many ways. And in that strategy is this bold statement that instability is the product of ineffective and illegitimate governance, and if what we're about is increasing stability in these countries so that social services can be delivered, then we need to work on these two aspects of instability. Legitimacy can be defined as the perception that government works for an entire population and thereby gains the support of that population, and effectiveness is the ability of a government to deliver goods and services, one of several core functions of government, amongst the others of providing security, controlling the arms that circulate within the borders of a country, improving the economic status of the country and creating markets for its citizens, and so on and so forth. On the other, that's a very political way of talking about fragile states. On the other hand, the State Department has also an interest in providing humanitarian assistance and poverty reduction and development writ large. We in the United States, it seems to me, tend to put a greater emphasis on the political aspects of working in fragile states at this time, whereas the Europeans have tended to preserve a more humanitarian approach to fragile states. The two can sometimes create tension, come in conflict, but they can also be seen in complementary light, and that's what obviously would work better for people. I want to skip a few because I don't have as much time today as I have on other occasions. But when it comes to programming in the health sector in fragile states, we've all talked, I'm sure that in the previous sessions of this series, that we've talked about identifying and working towards reducing the sources of fragility. And I think in the health sector, as I've said, we really haven't incorporated that adequately into our programming, and we continue to work on a more disease-specific, disease control mode, and working in fragile states is going to have to reorient our thinking to some regard, in no way in a substitutive way, but rather in an additive way, so that we take into account both aspects of what needs to be accomplished. So one way of doing this is to provide people with what they tend to expect, especially in the post-conflict setting, which is the so-called peace dividend, and we have to think of what that means and how to best provide that. There's a relatively limited window of opportunity available to convince people that they should make an emotional, a political, and a real investment in those fragile governments that take form following the signing of a tenuous peace accord, as is the case in DRC, which is in between elections now, or in South Sudan, or in Afghanistan, or any of those settings that we're familiar with. And finally, in terms of programming, I'm a great believer in the adage that what gets measured gets done. And we really have not, to this date, been able to develop, or maybe we've been able to, but we haven't seen it appropriate to, or something has kept us from developing indicators that can help measure whether or not the health sector is in fact contributing to increasing the stability, to shoring up the peace processes, to increasing the legitimacy of these fragile governments that without which there is a very, very high risk of recidivism of conflict and hence of a deterioration in the health status of the population. We know that more than 50% of civil wars occur in countries where there has been prior conflict within in the space of a decade. And that risk of recidivism remains high, and we ought to be working in every sector of operation, and in the health sector, in some instances, especially in the health sector, to do what we can to reduce that risk of resumption of conflict that would result in a total inability to deliver any health services to a population, and by extension in a deterioration of the health status of the population. Therefore, some of the priorities that obviously I've been talking about, enhancing stability and security, We need to encourage reform. These are all things that are found in the Fragile States Strategy that probably doesn't need to be repeated here. Not every post-conflict setting is the same, and there is a tendency sometimes to throw our hands in the air and to say that things are context-specific. Doing that kind of defeats a lot of what we've learned from various analyses. Things are context-specific, but there are also generalities and considerations that can be learned from the overall settings, and it's important, I think, to work from both sides, at the country level and at a more central level, to try to oversee the shape of programs that we have. There are a lot of problems in doing so that have to do with the fact that it's difficult, more difficult in fragile states to get information to help guide our programs. The human resource base is quite weak and can be fixed in some ways through creative programming, like diaspora programs that exist in some of the countries, but only if they're done well. We hear a lot of talk about low absorptive capacity, something that in the Millennium Project, in fact, we rejected, or rather said that this needs to be seen as a problem with a solution rather than an obstacle to providing additional funding and assistance. A number of others on this slide that you can see. Wherever there are problems, though, there are also challenges. And some of them are of our own, or maybe I should say of your own making, since although I used to work in government, I don't anymore. But it's very difficult. It's not only a problem of USAIDs, but of DFIDs, of the European communities, of whatever donor. Not one has really successfully negotiated the transition from emergency programming to post-emergency programming. The transition in USAID from OFDA to the more development areas is very problematic. It remains so, and needs really to be tackled with much more vigor than has been the case in the past. It really affects organizations like the IRC, which is founded as an emergency relief organization and now finds itself in I don't know exactly what the word is that I should use, but in a way trapped in many emergencies where their length of stay in a particular country has increased dramatically, and they find themselves having to modify and tweak and alter their programs. It's a little bit, I used the term mission creep to a group of my students yesterday, but I think that that's what you're finding, and my students didn't have a clue what that meant. They never heard of it. But it works in both ways. The emergency relief groups are finding themselves having to work in post-emergency settings, and similarly, the more traditional development partners for USAID and other development agencies are finding themselves drawn into unstable areas much earlier than they might have, than they traditionally are. So both kinds of organizations that we work with are struggling considerably. I think another challenge for the donors is to figure out how best to channel assistance to a young, immature government, if you will, and there are a variety of ways of doing this. Some, like USAID, like to maximally hedge their investments, working directly on a contractual basis to their own contractors, a situation that one of my colleagues has called state avoidance strategies, not necessarily what we want to do when we're trying to shore up fragile states. Others, like the African Development Bank, have basically provided economic support funding to governments that have yet to demonstrate their ability to deal with any aspect of government, financial aspects of it, the least. So somewhere in between, there are a lot of possible strategies. Everyone, I think, well, many of the donors and my colleagues like to talk about working eventually towards a swap-like setting, but I think that there's a lot of study and analysis that needs to be done before that we can do that. I think that from my experiences in the countries I've worked in lately, I have my own biases, but having seen the situations, I'm biased towards helping governments manage their public health sector, but manage it without delivering services and arranging with for private health service delivery in the peripheral areas. And that really gets us to the crux of what I believe fragile states programming should look like, because those private service delivery organizations, whether they're the IRC or any other NGO, when it's usually an NGO, but it can be church groups, it can be anything, all formulas exist. They then need to subjugate themselves, if we're talking about increasing stability, to the wishes of the public sector. They do this in some places on a contractual basis, but again, health service delivery is what they tend to be about, and they don't often see their role as being one of providing support to the fledgling government and increasing the legitimacy of that government in such a way that it will contribute to reducing the risk of a resumption of conflict in post-conflict states. They don't advertise on behalf of the government. They aren't given indicators, even by the government, that help measure whether or not they are in fact contributing to the legitimacy and the effectiveness of government work and allowing the population to get a better view of the functioning of that government. And so I guess that the basest way of saying this is that if you go to a clinic in a peripheral area of Afghanistan, even if an NGO is working there on a contract given to it by the Ministry of Health of the government of Afghanistan, you might find a big sign saying that this is brought to you by, these services are being brought to you by BRAC or by IRC or whoever, and then on the other side of the sign it might say, with financial assistance of the World Bank or of USAID or whatever the case may be. And nothing is said about the fact that it's the government of Afghanistan that has worked through all of these arrangements and accepted them and contractually agreed with the NGO to do that. And that leads to a situation where the wrong people are getting credit for the right things. I'm going to run out of time in a second. So there are opportunities that accompany these challenges, some of which I've mentioned just now. I wanted to close just with two things. You'll see the third bullet on this slide is that I'm not sure that legitimacy and effectiveness, those two contributors to stability, are really on equal footing. For me, having looked at several of these situations, I think the important thing is having people provide support and legitimacy to their governments. That's in the initial stages going to be what allows governments to get over the hump and out of the dangerous period where the risk of resumption of conflict is greatest. That means that there are different things that need to be measured before vaccination coverage rates, before ORT usage rates, and other similar indicators really come into play. And again, I'll repeat that we don't have those indicators yet. The second is that in the health sector, we hold equity really as a fundamental principle of our work. Equity meaning the equal distribution of resources and services. And one thing that USAID has been trying to do is it flies a little bit in the face of the way that the public health sector likes to work, and that is to say that absolutely equity is a must, but again, if reducing the risk of conflict is the most important thing or a very important thing, then perhaps equity comes a little later down the line. If we look at places, in a country like South Sudan, where the risk of conflict has been assessed, of resumption of conflict is assessed to be greatest in those areas where there was a presence of North Sudanese earlier on, and meaning that there were some health services available there, then it may be best to reinforce service delivery in those places where they already existed, and in those places where there has never been a vestige of a health system, leave that until the risk of recidivism is lowest. These are, again, early conclusions that I'm arriving at. Conclusions isn't the right word, but I think that we need to study much more what the appropriate stepwise way of building a health system is when at the same time as providing services we're trying to improve the likelihood that stability will reign. So the challenges and opportunities accompanied by potential solutions. Examples of them, I've mentioned the public management of private service delivery schemes. In East Timor, there was a tremendous, Chip can attest to this, there was a tremendous opportunity in East Timor to rationalize what was a very mal-distributed health system with many hospitals around and not enough primary health care. And in the wake of the conflict there, the UN in particular was able to work with the government to propose a redesign of the health system that resulted in the closing of a number of tertiary care facilities and expansion in the number of primary health care facilities. So they were able to do that. I just want to make a pitch in closing that many things take more time than we frequently give ourselves to accomplish. I think particularly with these fledgling governments, we need to be quite realistic and keep our ambitions modest. There's no reason to believe, as Enrico Pavignani has pointed out in some of his writing, that if a government was having difficulty providing health services to its population before a conflict occurred, there's no reason to believe that they're going to be any better at doing it after a peace agreement has been signed. Some things don't change and don't come for granted, and we need to take that into consideration as well. The harmonization and alignment discussions are, there's reams and reams and reams of writing about them. It never seems to quite happen in the field the way it's spoken about in Washington and London and Paris. More work needs, it's really to the benefit of new governments to have the donors harmonize their programs. I don't even want to talk about alignment because although donors mention the word, I think it's very difficult for donors to actually align their policies with those of developing countries, at least from their central levels. But in the countries I've worked in, specifically, USAID has, by virtue of the way it's gone about doing its work, has distanced itself in too many ways from some of the other donors, and in ways that could have been avoided by having more open and more frank discussions. Everybody respects the line of reasoning that USAID has laid out in regard to fragile states. The objections seem to come in the way that reasoning it plays out in the field, in the processes, rather than in the intended outcomes, and I think more care ought to be paid to that. Let me finish this the way I finished the recent paper that I wrote for USAID by saying that at the end, none of this works unless funding levels are going to be adequate. Whatever I say here, however strong the reasoning is, however logical anything is that any of us are saying, no health system is going to function effectively in any way, either on the service delivery side or on the or in working towards increasing stability within a country, if it has $2 per capita per year to provide. Funding levels are just going to have to be provided that give governments a little bit of leeway to exercise their work in a creative way and to make things happen from their capital cities out to the periphery. And that funding, which, the Millennium Project that was mentioned before, has costed out what it takes to provide essential services. Before that, the Commission on Macroeconomics and Health did it. Before that, the 1993 World Bank report Investing in Health did it. And we know that the levels of all of those exercises are far, far higher than the combined inputs of the donors. And there are efforts, I know, in many circles to increase the level of funding going to the health sector. There are also efforts to decrease the level of funding going to the health sector and use it for other things. So the health sector has to be careful to guard what it has and to advocate strongly for increases in funding if any of this is going to come to pass. I'll stop there, having gone on too long already, and let Emmanuel and Liz provide more specifics. This one.
I'll give my presentation sitting as well, though I have to say that standing and while giving presentation is one of my main weight conservation strategies, so I'm afraid this is going to have a lot of impact. I thought I was going to be Ron Waldman for 15 minutes, but not so. So I agree with a lot of, not all of what Ron said, but I don't know about the trap thing. But if I had known, I would have perhaps renamed my presentation, trapped in the long-term view, a view from the emergency side. But I'm going to divide my presentation into 4 parts of unequal length. And the idea is not to go thoroughly in each of the into each of these areas, but to present some ideas that hopefully we'll have time to discuss at the end, and also provide just some illustrations of the points that some of the points that Ron mentioned. So you can think of it as the kind of dim sum approach to presentation. If you really like one bit, you can order the full meal at another occasion. So I'm going to talk a little bit about population fragility, just because in talking and preparing the talk, I was told that this is something that this group has been interested in, and wanted to mention some thoughts of that relating from the field experience, particularly in Wamba. Talk a little bit about fragility in health, knowing that this group has had a lot on that, and that most people are sold. So I'm going to go very quickly on that. And then talk a little bit about illustrating some of the points that Ron has made about what contribution does health make to reducing fragility. And then talk a little bit, put actually our USAID funding on the line by talking a little bit about how missions and USAID plays into that, and some of the experiences we've had in the field with that. And I'm going to primarily base my examples from 4 countries, which are the 4 that I work in the most, which are South Sudan, or Sudan, I should say, Congo, DR Congo, Rwanda, and Sierra Leone. You see sort of on the west side there. So talking a little bit about population fragility, it's become, I think, a little less so, but initially was a kind of taken as a matter of course that a big contribution to the genocide was overpopulation. And this quote from the American Journal of Public Health is fairly typical. I was able to find many like that illustrate kind of the thinking, that all the other factors are secondary, and it's just basically these Africans reproducing. And I just came from France, which is where I'm from, and it's just amazing what you see as a standard fare in newspapers and all that, how that perception is very strong. And my first reaction when I read a quote like that is, first of all, to think of individuals, because it's kind of, viewing things as a kind of overall mass, and just, all these Africans, and they're going to invade us, and there's a lot of them, and look at the problems created by that. And then my second reaction is just try to think about it a little bit calmly, and think, what are the arguments for against it? And one way is to think about it in the genocide, the Rwandese genocides, think of the factors that are related to resource scarcity, and then think of the ones that are not related to resource scarcity. And I think there's definitely some in both categories. Some of them related to resource scarcity are popular discontent due to food scarcity, as well as to other reasons, but that, again, from previous Tutsi pogroms, where people, as people say now, the genocide started in '59. Really, that during those sort of mini genocides, people did gain, and they were able to take over a house or some fields, and so in a way that's related to people not having enough resources and a motivation to do it on a bigger scale. The fear of losing land to the invading rebel army was very real and stated at the time. If you look at newspapers of that time, it was played upon very consciously. And joblessness, which in addition to creating popular discontent, also meant that there were a lot of people, particularly in urban centers, who didn't really have enough to do and who were available to create trouble. And certainly there's arguments for that. The Rwandese population has grown quite a bit, and you see the little blip in the yellow is a famine that occurred around World War II, and then obviously the big dip is due to the genocide. So that looks very striking when you see it that way, and you see that the average landholding decreased quite a bit over the period prior to the genocide, because as a pretty much direct relationship to as a direct cause from the overpopulation. And then food production reduced for several reasons, but obviously the average landholding had an impact on that. So if you think of genocide as necessitating kind of 3 conditions: the desire, do I want to do this? The ability, am I able to do this? And then the permission, will they let me do this? You can see that particularly for desire, overpopulation can be argued to have some kind of role in leading to resource scarcity and popular discontent. But if you look at the argument, or what was proposed in the beginning quote, was not just that it was a contribution, but it was the main reason that people in a frenzy of political correctness, mention other reasons because they don't want to look at that as the fundamental reason. And it's true that Rwanda, compared to the African average, is very densely populated. It's the most densely populated country in Africa. But if you put it in context, it's slightly less populated per square kilometer than its former colonial overseer, Belgium, rather, and much less densely populated than the most densely populated country on the planet, which is Bangladesh. And there's a lot of reasons other than resource scarcity, though some could be argued to indirectly come from high population density, falling commodity prices, popular discontent because of egregious mismanagement from a very incompetent government, basically, an elite worried about losing power because of the rebels and because of other reasons. And I won't go through all of them, but the media is a particularly important thing to mention. And the power and the way the media was used and really made the genocide possible is something that when you, again, read what was actually written at that time, you realize it wasn't just transmitting, it was actually effecting the genocide. And lack of filial bonds, that's a more subtle argument, but something goes along the lines of what Jared Diamond talks about in Guns, Germs of Steel, that people's organization, the way they relate, is conditioned by the population density, but that people did not, if you go, for example, to Senegal, people really think of other Senegalese as their relatives in one way or another. Even in a different caste, you're in a different caste, but our families have been related for centuries, whereas in Rwanda, that's not how people view each other, by and large. And then international inaction, and in the case of France, my country, actual complicity. So there's a lot of other things other than overpopulation playing a part. So just to illustrate about the falling commodity prices, the price of coffee plummeting, which is one of Rwanda's main exports. So it's true that overpopulation played some kind of role, but if you look at every level of the kind of three things that have to happen for a genocide to happen, there's a lot of other factors that contributed. And so it certainly was not a sufficient condition for genocide overpopulation. And you could even argue, maybe not talking about genocide, but general state disintegration, whether it's a necessary one. Because if you look at, these are the four countries I'm most familiar with, and all of them have had big problems, and their population densities are quite low. Sudan has very low population density, and they've had more than enough trouble. In fact, looking at this, you could say that the presence of abundant natural resources is one of the biggest factors causing fragility rather than overpopulation. So it's not to say there are a lot of reasons why I think population programs are good, and individuals, most women in Africa actually would like to have family planning, and it's not saying that it's not a very important thing, and we work on that. But the idea that it's because there are too many people in Africa or they're having too many babies that that's where the problems are coming from is, I think, fundamentally misleading, both about the cause and effect relationship and also how important that cause would be. Now I'm going to talk very quickly about fragility in health because I think, again, most people are sold here. Certainly Chip up front knows this better than I do. And just cite some of the many reasons from the obvious ones. Security. If you can't go out or if you're worried about getting killed, then you're not going to give any health care. In Bukavu, in the area around Bukavu, which saw some of the worst fighting in DR Congo, nobody lived in the clinics, and some of them would go out there during the day. Well, let me tell you, health care suffered. From policies, the inability of a government to propagate proper policies has direct impact on service delivery. I can tell you as someone who's provided health care in peripheral clinics, it's really frustrating when the government doesn't tell you certain things or help you, with decisions that have to be made. And then conversely, when they do, it really makes it easier and empowers you. Motivation and training of all the actors in the system. I think what Ron said about human resource management is key, and when you're not having the state bureaucracy properly managed from a human resource point of view, it's really difficult to get things done. And then the communities there's a complex cause and effect relationship as well that goes both ways, but one of the things that occurs in fragile states is communities can be dysfunctional, to put it that way, or have been various stages of dysfunctionality, and that really affects, particularly when you do community health programs. And again, in a country like Senegal, which I would argue has great social capital, it's incredibly easier to do community health there than it is in a country like Sierra Leone, where you have all sorts of endemic corruption at the village level, which was one of the causes of the country's problems at the national level. And this has direct impact. Just as a contrast, this is from the same program, from the same donor that we implemented in Rwanda, which I would argue is much less fragile at this stage than Sierra Leone. And in Rwanda, the program, took off. And this is with the same money. Actually, more money was allocated on the Sierra Leonean side, the amount of treatments that were done, of kids that were treated. No comparison. If you take the kind of area under the curve, which is the total amount of children, you find a difference of close to 100-fold. And why? This is just to give you a few examples. In Rwanda, the government had the wherewithal to, first of all, put together an application to the Global Fund for malaria drugs. And then the National Malaria Control Program negotiated to have blisters done in the national language and prepared, and all this was done for us. So we were basically even getting money for training from the national government. We were almost paid, not almost, we were paid by the national government to do some things as subcontractors in a way, and had all the equipment provided. Well, it's incredibly easier versus Sierra Leone, where there was no policy. They said, well, go to the local level. The local level said, well, go to the national level. And we had to get our own anti-malarials. And, of course, no blisters in Creole. We had to do it all ourselves and couldn't do that. And then same thing, we had photocopied registers, and we had come up with a template. In Rwanda, the government looked at this and said, this is good, but there's a few changes that need to be made, and plus you need to print it as registers. We'll take care of it. We'll give you the registers. I mean, this is a degree of function, and it really makes a difference because, as our staff told us, the distributors take this much more seriously when they see the government's printing the registers. Plus, those registers were really well designed. We wouldn't have thought to do it, a triple copying register for reporting. So this is, in many ways, a highly functioning government, and it really makes a difference. It means that things get done months earlier, that everybody in the system is more motivated, they see it's working better. So all these different things end up having cumulatively a very big difference so that you lead to that kind of difference. Now, talking about health and fragility, and that's, in some ways more controversial, and it's true that we, the health people, are kind of singing for our supper, arguing that in this whole fragile or post-fragile framework, we have our place, and of course, I strongly believe we do. One of them is, by definition, if you don't have health services or you don't have good health services, you're in a kind of fragile situation because you're not providing one of the basic needs that people have. So what's the point? If people in areas which on top of it have extraordinarily high burden of diseases, naturally, as is the case for sub-Saharan Africa, like malaria, and you're not providing drugs for malaria, then, there's something pretty fragile about that. So if you're remedying that situation, at least to some degree, you're making this less fragile. Good services legitimize governments, I think, and Liz will talk a little bit about that. There's a lot of questions about how, it makes sense. We haven't really proven it. I would add, as a corollary to that, good services also kind of are more efficient and make better uses of government policy. This is a little cost analysis we did in South Sudan, looking at the cost of the community versus facility programs. And in addition to being community and facility, I would say, in a completely biased way, that the community program was better run. And I'll go about that in a little bit. It's just a better run program. And it was able to deliver services at a much, much lower cost. And some of that was because the costs were a little bit lower, but mostly it was because the number of children who were treated were much better because it was better organized, better managed. And that, I think, does end up making a difference, particularly on a national scale, if you do the program on a national scale. The other argument is that the health is an entry point for building systems. Health systems are concrete. People understand what they're for. And the health systems aren't that difficult to put in. And in countries like DR Congo, where there's such a yearning for systems, and you have a fairly educated people, and they're tired of working in systems that are basically meant for looting or for subverting the public good. A lot of people, most people, want to work in systems that work. They're not particularly interested in accumulating private fortunes, and they know they can't. And so health is a good way to do that. I'll give you a little example from Rwanda, where, of course, it's, as I said previously, it's a little bit easier to implement systems. These are traditional birth attendants, and this is a program that we ran in, that I just unfortunately deleted the graph. What that graph would have shown is a steadily rising curve of the number of people treated, or of women who deliver in health centers. And that was matched by an increase in the number of referrals from traditional birth attendants and led to a similar increase. It's really a neat graph. Your loss is tremendous, but in the number of cesarean sections, which kind of tell us that these referrals are actually, some of them at least, are the women who should be referred. And all of this was done through systems. Because what happened is we did two things: a human resource system, meaning a way in which all of these traditional birth attendants were reported, and a way also in which they could be supervised by the health center people. And then an information system where they gave reports, and we were able to see what percentage of cases were being transferred. And it quickly allowed us to see where the problems were. And we weren't even participating in the solutions, because once the solutions the problems were identified, the district person, sometimes even the local person, the health center manager, was able to find out what was wrong. They could find, for example, a woman had died. It happens. A woman's sick, she gets transferred, she dies at the health center. People conclude it's not healthy to deliver at the health center. But if you see there's a plummeting of referrals there, then you go and you address the issue, you go talk to the population, maybe the local political authority is involved and sensitized. Or in other cases, it was because the health center manager really didn't have a good relationship with traditional birth attendant, insulted them or threatened them when they referred to patients and all that. And you can do something about that because you have the information. As Ron said, one of the key problems is that you do not have information in fragile states. As a public health person, it's just appalling. You just don't know anything. And that information isn't that hard to get. And you really can get it through public health. And putting that system has an impact and is something that can be replicated in other programs, non-health. To talk a little bit about South Sudan, and they're comparing it to Sierra Leone, and again, not quite what we saw in Rwanda. It's still very small scale, but still, if you look at the area under the curve, you'll see that there's many more children that are treated in South Sudan, even though the area covered by the same program, this community treatment program, was much smaller. And South Sudan is a really difficult environment to operate in. But it worked very well. It worked much better. And I should add that the quality of the program of the services provided by the women was very good. Good human resource management, good information system, simple tools, and there were all of our programs each contributed to tools, but the South Sudan's contribution was much greater than the others. They have a very manageable and scalable program, and it was adapted to the local environment. And a lot of that was, I would give credit to the manager of the program, a Kenyan man called Johnson Wamba, who, in very typical fashion, kind of stands behind his distributors. He's a very unassuming, low-key guy, but he's a good manager, and he really focused on systems, and it made this kind of impact, where you had many more people treated. So I would argue that this kind of system definitely has an impact on health and can be done. You can implement that in areas that are very fragile, such as South Sudan currently is. It's not impossible, because a lot of the unspoken argument is that you can't really do this in fragile states. And the answer is you definitely can. You can put in systems, and why not do it in health? Because it's concrete, the population definitely supports it, and it's not that expensive, I should add, but I'll get into that later. So another argument is that systems may induce more responsibility. Going back to the Congo example, most people really do want to work in systems and want to contribute to the whole, but they don't want to contribute to that if they're the fool by playing that game. And systems allow people to feel like they're contributing to something, and they're being rewarded for contributing to the public good. And community work strengthens communities. And I want to go quickly through the example again of South Sudan, where part of the reason that program succeeded is that at the outset they invested into going village by village in over 100 villages, say hundreds, like this, carrying their own chairs because a lot of places you can get to by car, having community meetings, and convincing this village chief and people like that to let women, for example, be distributors, and to not name, if they're a woman, not to have it be his wife, which is exactly what damaged the Sierra Leone program quite a bit. And because the manager, and also, well, first of all, the manager chose great South Sudanese staff, and they had a good understanding of this dynamic, and they were able to tread that thin line between respecting what the community wants, but also not allowing the dysfunctions within the community to then impact on the program. And I would argue that that's leaving the community stronger, not just for health, but for other things as well. So in Sierra Leone, they made literacy a requirement, big mistake, I think, and had, as a result, 20% of the distributors there are women. In South Sudan, 4% are literate, but they chose the people who are most dedicated to public health or to helping their village, and they found 81% of them were women, interestingly enough, such as this woman here using a UNICEF timer to assess a child's respiration. And even though they're illiterate, and even though the population itself, particularly the chiefs in the beginning, were like, women can't do this, the quality indicators were very high. I can't even compare this to the Sierra Leone indicators or the Congolese one, though having been there, I can tell you they wouldn't be nearly as good, because they're not even managing to collect the data on a wide enough scale for us to take assumptions, whereas they're regularly collecting supervision reports, entering it through a PDA into a database, and doing extremely well. I won't go through each of the indicators, but the basic point is that they're treating the right people at the right time with the right doses of medicine. And as you'll see at the bottom, others who rate their distributor highly, most people are very happy with the service. Now, to go back to some of the questions Ron asked. So, poor information, these are the key features of fragile states. And can health programs help? Definitely. I mean, that's a big thing that we can do. We can get information, not just about health, but about mortality, which reflects a lot of things other than health. It's not always easy, but it's possible. Weak human resources, definitely. Again, as Ron said, you can't, reverse decades of lack of higher education or flight into cities or other countries, but you can make people very effective. As anyone who knows, who's worked at the community level, Africa is filled, any place is filled with people with will, with smarts, who are able to do quite a bit. But there are no systems to unlock that human potential, and you can do it, and health is a good way to do it. Weak absorptive capacity, actually, I think that's more questionable about whether we can change that, but certainly by having health programs, we can help, and good health programs, we can help to spend some of the money. Uncertain future, can't do much about that. The unpredictable external support alone, we can't do much. Or about the recidivism. We see what's happening now with the Taliban in Afghanistan. And Afghanistan has a great health program, but that didn't stop these wider forces from coming into play. It certainly addresses needs and helps us to show a peace dividend. In Rwanda, the child mortality has decreased by 25% over the last 5 years, from the 2000 to the 2005 DHS surveys, which is a remarkable achievement. It's interesting that it doesn't get as much play as I think it should, and it's a combination primarily of the state being less weak. And again, continuing into some of the possible activities or actions that Ron mentioned we could take. Well, I think that health can contribute to encouraging reform by being a reform. It increases capacity in key areas, if we still accept that health is a key area. It can have short-term impact while at the same time having long-term reform. And we're definitely, as we talked about with the information, we can put in measurement systems that have wider human rights and population well-being sort of implications. And to give an illustration of that, these are indicators that come from health, but I think can be viewed to some extent as institutional indicators of how the country's institutions are doing, like utilization rate, the number of supervisions are documented per month per health center area, the number of people who are giving reports at the community level, and stock out. These are all health indicators, but they're also institutional indicators. So now this is where I play Russian roulette. To talk a little bit about the view from the field of how it plays with USAID, and I'd be interested to hear feedback. And I realize that some of these things are outside the control, certainly of the missions and possibly of the people at the very top levels in USAID, because they depend on a lot of things. But starting with the assumption that missions are very concerned about fragility, and that's something you find in all the missions, that they're very aware of the political framework. But they also care about health status. That's true in most places. I think some missions are more aware than others. And I'd like to talk about what the missions do that help, and what they do sometimes that doesn't help. So just to go quickly to frame the discussion, starting with a mea culpa about NGOs, because what missions do often is work with NGOs, and you have to recognize that NGOs have weaknesses and strength. Strength, I think, is that they're often close to the field. closer than USAID. They're collaborative. They're coordinated to some extent, and they work better when they're coordinated, and they think of scale-up sometimes. What doesn't work so well is NGOs are very expensive, international NGOs, compared to other modes of operation. They often have very short-term, they follow the donor, and so they think in the short term. And that's true of cooperative agencies sometimes, and they realize that the institutional memories are quite short. They often work at a small scale, and they're not really audited. You write reports, but all of that I told you about South Sudan are results in Rwanda. Like, who's going to actually check that? I must say the Canadian government goes and sends somebody to check, but even then, we know that unless you're careful, you have mechanisms, you can get taken on tours. There's really not a lot of checking of what NGOs do. So things that don't help. One is frequent strategic redesign. A terrible quote is a consultant, an evaluation consultant who went in, the mission said they hadn't been to the field in a year because they were redoing their plan. He said he had never been to a mission that wasn't about to, in the process of, or had just completed a strategic overhaul. And that really, I think, in the end, impacts efficacy and means a lot of sudden shifts as sometimes people go. The process of strategic design. I don't know if some of you have read a book called The Wisdom of Crowds, which I just read. Fabulous book. But one of the key points is that the more people with information from different points of view come together and participate in a process, the better the result is going to be. And sometimes there's a very good process of including people. But there are times when it's a bit insular and it's people in a room who come up with an RFA and then everybody complains about it. And I think that's something that can be done about. As I talked about, sometimes because of the strategic redesign, the way the missions are set up doesn't favor going to the field. And when there is going to the field, often it's in a bubble, and so you get protected from a lot of information that would be very useful. I don't know if you know Paul Theroux, the travel writer, had a great story about how when he was in Peace Corps, he'd get invited by this guy and everybody would have to tell a story in order to have dinner. And it was the CIA operative from that area. But in a way, that was like if the CIA did more of this, would probably be better off, to get that kind of information. Concentrating resources. And I think there are places where it's legitimate, but mission after mission has this thing that we're going to operate in a few areas and really get results in those areas. And I think that really loses an opportunity to work at a broad level and to have the impact nationally that USAID can have. So I think there are times, like in Sierra Leone, where it makes sense at working in a fairly wide area on the east, which was, preponderantly the victim of the violence and suffered the most in the 10-year civil war. But there are times when also you're working in tiny areas, and the government, I think, very legitimately get angry about concentrating resources and having something that's not really scalable or reproducible because it's so expensive. And where people start thinking, wow, there's so much money there, how can I get some? Instead of, let's try to make this work. And then sometimes there's a little bit of a disconnect between DC and the mission. You're probably aware of that, but you come and you say things that you've gotten from a USAID workshop or a seminar, and the mission has not heard about it or is telling you the exact opposite. And I would say it varies quite a bit. There are some people who visibly get better information, but there are some missions that seem to be more isolated. And then some regulations, and I realize it's not within the control, and often, the people in the missions are as frustrated as we are, but the idea that you can't buy generic drugs in many cases, I mean, that's crazy. And then salaries. I think that's a whole discussion, but the idea that you can't invest in people really, really demotivates some of our national partners and ends up being a lie because you can't even work with if you apply that completely. So there's per diems for training and other things. So you get mechanisms that have a lot of bad side effects to basically do the same thing. And I think that's not the best policy. I understand the concerns about sustainability, but as Ron said, you've got to have resources. You've got to have resources. If you don't, then you're not going to get anywhere. And if you don't acknowledge that fact that you need resources to make vast countries like Sudan or DRC work, then maybe you shouldn't be working there at all. And then the short-term funding, and that's particularly true within the OFDA context, but I can think of no single factor that has more negative impact on programming because everybody's energy is spent on starting up and then closing down the program, and you can't really set up. And also people who are on the beneficiary end, which includes really our local workers, know that people aren't really investing. And so it totally changes the mindset of our national staff as well as the beneficiaries. There are a lot of things that missions do that help. One of them is having ambition programs designed for scale. I don't always agree with how the RFAs are run or what they contain, but the idea that you have these big ambitious programs I think is a good one. And although I haven't been personally associated with it, SANRU I think is an example of a program that is well conceived in that way to operate on a wide scale, not too many resources in any one area, but really trying to have something that could be reproducible. The coordination of grantees, and the Wamba mission did when we were putting together the grant that we currently have with 2 other NGOs, and there were a lot of internal problems between the NGOs, and the mission did an outstanding job. Matt Chico, I think, particularly deserves singling out of bringing us together, and I think USAID has power and is in a great position to do that. And I think that's something that should be encouraged more, and having people who are good at this type of thing be in the missions. Coordinating with other donors, the multi-donor trust fund in South Sudan is an example of, I think, a great idea. And as Ron said, it's difficult and there are limits to it, but the more that's done, the better it is. Grantee government mediation, again, USAID is in a position of power with the grantees, but also to some extent with the government, and can use that to, and has used that for a lot of good. The intersector synergy, same thing. And then I think that USAID stands out as a donor that's willing to invest in systems. In Rwanda, for example, they sponsored the Voxiva-led TrackNet system, which is a model information system for HIV. And nobody else would have spent, over $1 million to get that system underway, but it's a good investment. And long-term funding. There are examples with OFDA funding of short-term, and it can be very damaging, but missions often work on a 5-year grant cycle, and that's very helpful, and a lot of donors don't do that. So the key, I think, is making sure that everybody contributes, and the missions are in a very good position to kind of coordinate this process so that everybody speaks. But I think missions work best when they listen and they coordinate, and they have all the different actors contribute what they can. But USAID is in a unique position to crawl this. And I think if it thinks of itself as doing that rather than having to do it alone or just doing one particular program, they're going to function better. So I think as logical conclusions from these observations, thinking big is a good thing, I think, for missions to do. Focusing on coordination and on systems building, rethinking the direct procurement and salary support limits, and then rethinking the strategic planning process and not having it as these kind of wild swings on a sailboat, but having smaller adjustments. So process you could continually improve because you do continually get more information and learn more in the country shifts. But if you could do it like a gradual turn rather than changing tack, I think that's going to be better, and having as much participation as possible. For OFDA, I won't belabor this, but I think that if OFDA could still do some of the things they do well, like having a lot of inputs and realizing some of the higher cost out front, but not do this short-term funding. In all the countries where I've seen OFDA, in the end, you end up having OFDA funding for 3, 4, 5, 15 years, and for South Sudan, and every year it's renewed year to year, and there's this change or that change, and nobody can really invest. And I think that what you lose in one case where they shouldn't have made a long-term investment, you'll more than gain in all the cases where you're going to have anyway lots of years of FDA funding. Doesn't mean you don't have some emergency mechanism and flexibility, but a 6-month grant really is difficult to justify. And the other thing is to increase monitoring of costs and results. I mean, the other thing I've seen with OFDA grants is how little accountability there is. And I don't think that has to be the case in emergencies. It definitely doesn't. So bottom line, I think fragility affects health a lot. I think we've all seen that. Health programs can reduce fragility. Some, I mean, it's limited. It can help with systems and measurement. There's a lot of other things that play a role, international politics and arms dealing and all that. But I think that it has some role. It can certainly reduce suffering. That's a reason to do it, and at a very manageable cost. And I think the missions are helping a lot, but could help even more, particularly by having more stable strategies and focusing on stable funding, and then coordinating and listening, to what the people around them have to say. And I think this slide is my signal that it's my turn to listen.
Can you just flip
Sure.
the IRC one up? I do want to be in that. Just as national speaking. I need glasses. So, hi. It's great to be here, and thank you as well for the invitation. My presentation will actually be fairly short. In following both Ron and Emmanuel and having seen their presentations, I thought what I would do, they really covered the macro issues and the health issues and the issues about fragile states. So what I thought maybe I would do is just take a really short period to talk about how, as an agency, we try to operationalize service delivery in fragile states with conflict-sensitive approaches. So kind of taking it off of looking at it more from I'm a practitioner, I'm a post-conflict person, not a health person. I need glasses, sorry about this. Page down. Okay, so to start, I mean, it's something we've already talked about, but and this is nothing new to people in the room, but just as a reiteration. The issue of fragile states, poverty and lack of democratic governance are seen as the primary cause of fragility. I think we all know that. In many ways, the international community understands that governance is the key to stabilization for fragile states. But what I see on the ground, still to this day, is that we still attack governance in transitions and in fragile states through governance programs, okay? Not through service delivery programs. We're still doing that. And we're doing it through broad-based programs, elections and rule of law programs at kind of national and provincial levels. We'll do very broad-based civic education programs. You see a lot of that on the ground in fragile states and in transitional environments, civil society programs. But they're often not targeted at the grassroots. And that, for me, is a significant problem, in that the grassroots is the base that's going to sustain good governance. So if we're after good governance in countries moving forward, if we don't start targeting communities more and more, we're going to have a problem. We're never going to achieve the end game result that we want. And so one of the things that that really I think we need to start looking at is, we need to be targeting governance at all sectors, in all sectors, so in the service delivery sectors, as we all have talked about, it's part of the fragile states strategy, but also far more on community level. And so, when the question comes up to me about how do you demonstrate that health supports governance objectives, I think we can actually turn that on its head a little bit and say, how do service delivery sectors may not just be the way to instill government, it's the way to get at it. Okay, service delivery sectors can instill good governance objectives. And this is something that we haven't really pushed forward hard enough. And it's not just in health, it's in education and Watson. If we were really attacking governance through all the service delivery sectors at community level, I think we would have much better results than what we see today. So that's the first point. In theory. Excuse me. Okay. But this whole issue is something that IRC as an institution has been grappling with, and we grappled with for the past couple years. And we were concluding about 2 or 3 years ago kind of the same learning that's coming out of the fragile state strategy and what I just talked about. And so we decided that if we were institutionally going to bring this new thinking to our agency and to be able to operationalize it, how are we going to do this? And what we did was we put forward an institutional program framework, which is this. So going back to the opener, root cause of conflict as a cause or fragility is really related to poverty and bad governance. So it's grounded in that thinking, number one. So IRC now, in the past, as a humanitarian agency, we used to respond to conflict and the impact conflict had on communities. Now we need to flip that and not only look at impact, but we need to look at root cause issues. So that's kind of the major shift, and I think many humanitarian agencies are going through that understanding right now. What the framework shows is that from the beginning, and I'm just going to focus on a short side of it to keep this very short and simple, we actually are focusing on durable solutions from the outset now. That's what we want staff to be looking at. From the time they enter an emergency, immediately following an acute crisis, what is the long-term goal here and how are we going to get there? That's the aim. And the second thing we really want them to focus on are the 3 aims. Okay, so if you think about our entry point is saving lives. And it's saving lives in conflict zones, although sometimes we do this in natural disaster, but in conflict zones. After you do the saving lives, you move off of saving lives into meeting basic needs, and from meeting basic needs, you move into looking towards the MDGs. Okay, so that's the progression of one of the first aims, and that's the aims that we're always historically used to working towards. But what we're trying to really push staff and push the agency to understand and is that they need to go beyond that, and they need to start to look at strengthening institutions, all right? And by institutions, we're not talking about state institutions necessarily. We're taking institutions in the broadest sense of the word. So civil society, community institutions, state institutions. But that we have to do that, and here's where the social cohesion piece comes in. It's insufficient to just do meeting basic needs and building institutions. If we don't do it in a way that brings communities back together again and brings communities back together with their institutions, which is what conflict has destroyed, then again, we won't be successful. And so this is the big mind shift for the agency, if you will, or the attitudinal change for the agency. All right, so, and you know, it's a very difficult change to facilitate within an organization who historically kind of focuses on the first tier. But it's happening, and it's happening with a lot of energy and a lot of positive energy. So I think, you know, the light is good. Our challenge, okay, I'm going to skip this one to go faster here. Our challenge, or our perceived challenge, is defining the indicators and the measurements, because you know we have the indicators for the basic needs and the saving lives, but we don't necessarily have those for the institution building and the social cohesion, which many people find are the hardest indicators in a transitional or fragile state setting. Although I think that we're finding institutionally that it's a little bit easier than we actually understood or acknowledged. That there is a lot about institution building out there from the development sector that can be adapted and is being adapted and needs to be adapted to the fragile states in the conflict environment, and we can take from that, and we are taking from that. Likewise, the development folks have to take the social cohesion indicators and how you bring communities back together and adapt those down. And it's kind of putting those together into frameworks, which is what we need to do. And that's what really the agency has been trying to work on. Equal to the indicator is how do you get generalizable learning for fragile states? Okay, so that's our next question. And so what we've done as an institution is we decided to, we're in the process of it, so it's at very early stages, and I don't have a lot of findings to present yet. But we decided to look, let's take a pilot of a certain sectoral program, and we did one that I actually have a lot of expertise in so that I could work with it. It made it easier for me. And look at community development in a reconstruction setting. And so what we did was, over the course of 3 years, we looked at all of our programs that did this work in transitional and fragile states. We defined a best practice framework. We brought all of our practitioners around the table again to re-vet that best practice with some academics, and we were working with Stanford at the time. And we came up with a best practice model, okay? And so what we did is we're using that model now in all new programs going forward in fragile states, but clearly insufficient in that we don't have credible evidence yet to say this model works. And so that's the next big hurdle for us. And what we did was we've now started to work with Stanford's Center for Democracy Development and Rule of Law to look at and understand and attribute impact to our work and to the donors' work. Okay, and so we're looking at those three issues again: good governance, the livelihood issues, and social cohesion. And I can give you examples of the types of things that we're looking at within each. But for instance, good governance. As a result of our work, are we increasing citizen participation? Is the community more likely to understand their role vis-a-vis the authorities? Okay, and vice versa. Are the authorities able to? Are we having improved access to services? Because this kind of community development program only does that. Okay, it doesn't improve quality, it improves access. End of story. Social cohesion. Are we bringing communities back together again through these processes, or are we dividing them? And so the aim is that we understand this. And we're doing it in Liberia right now. We've just finished the first survey. We're getting ready to do some variation in treatment in a CMM project that will go forward. And we're going to be doing it in a large scale again on DRC so we can have cross-country comparisons. Okay? And then we know whether we have some real learning here going on, and it's not just individual country specific. And so the aim for us is if this actually has worked. I mean, in theory it works. The process works. And what we want to do is take, for instance, all the learning that Emmanuel has from child survival, and he's done 5, 6, how many programs? 5 programs, in fragile states, in transitional settings. This is a first for child survival, as far as I know, or is among the first. Let's pull that out. Let's define the best practice. Let's do it with really credible, scientifically valid impact evaluation, and then let's start to share that out. So that's institutionally where we're trying to head. In terms of, we're just there. Like I said, we just finished the community reconstruction. We'll start to move to health and education next. It's going to take time. It's going to take a couple years to do some of this work, but hopefully we get there. And when I was thinking about, when we were talking about how to just make some recommendations to USAID, I think the only 2 that really kind of popped into my head is that it was interesting in doing some of this work of how difficult it was to get the field donors to understand the need for us to do this in the face of needing peace dividends and us pushing the process out. And we need to flip that somehow. And I don't really have an answer to that, but because I recognize the need for the peace dividend and you recognize the need for things to happen. I think that, though, the more we get used to doing this kind of survey work and this kind of evaluation work, the quicker we'll get. And so we won't be cutting into the peace dividend time, which is the big issue. And the second thing is I think that USAID probably could be more demanding of us in our proposals and in our reports on data in these environments. Demanding in that I said we have to work as partners because it's not easy to do this stuff. This survey with Stanford was really tough, actually. But it was done, and it was doable, and the mortality survey was done and doable. So, we've been proving that you can do this kind of data collection. So, that's it for me.
Thank you very much, all 3 of you. Appreciate it. There's an awful lot for us to chew on. We have some time to do it. Why don't we open the floor up, just for the benefit of our guests and everyone in the room. Why don't you let us know who you are and which office you're with? But who would like to kick us off in terms of the discussion?
I have a general question.
Okay. Sir, if you could use the microphone so that we'll have it for the video as well. Thanks.
Hi, my name is Stephen Satimi. I work with the Global Health Bureau and USAID. And this question is for any and all the members of the panel. And thank you for your presentation. It was very interesting. Both Ron and Emmanuel brought up the absorptive capacity. Emmanuel mentioned, I think Ron did too, about the need for higher funding. What is your impression of high levels of funding where there's not the absorptive capacity and the impact of that on fragility? Because we do have very high levels of funding in certain countries, tens of millions, if not hundreds of millions of dollars. And in one country in particular, in the Middle East, probably billions of dollars. When you look at absorptive capacity, what kind of comments can you present from your field experience on institutional capacity for absorbing those resources?
Actually, this is something we've thought about quite a lot. I think Ron put it perfectly. This is a problem with an answer rather than, or that could have an answer rather than an obstacle. I think you have to view it not as an absorptive capacity, as almost a feature of the country, but more a feature of the donor. Do you want this money to have benefit? Are you willing to invest in the monitoring and evaluation, in the systems building? It's a question of how you spend that money. I mean, we know that billions were given to Mobutu, right, in Congo in the 60s and 70s and 80s, and not a lot of good came out of that, and that's because people weren't really giving it to help, right? They were giving it to buy access and influence and that kind of thing. But if you really want that money to have impact, I know firsthand from being in the field level, it's not easy, but it's not also impossible by any means. It's not even always hard to put in place mechanisms to see that that money is spent well and to make sure that it's spent on the things that need to be spent. There was so I think that when you talk about absorptive capacity, you're really talking about the willingness, by and large, of donors to make sure that the money gets where it gets to. People often say in the papers, it's a widely held perception that you can't give money to these countries because they'll squander it. Well, they'll only squander it if you let them. It's not hard to to stop that from happening, or at least to reducing it to levels that are acceptable. So that's what I would say. Just to illustrate that with an anecdote, on TV, there was the Belgian ambassador in Congo on the national TV who said, yes, we're giving money to pay the soldiers, and it's reaching the soldiers. And I was watching this with someone who works for the UN and who was visiting the soldiers themselves who were not getting paid at all. And it's not hard to verify that. You don't need a ton of people or to even carry the money to specific garrisons and to give it to the soldiers, because that's what you have to do in Congo. And you have to be really, not caring that much about it or not focused enough on the money arriving to just give the money to the Congolese army and expect that it'll go, because the systems are so messed up that, again, the guy would be an idiot to pass the money on, because then it'll just get stolen at another level. And there are things that you can do about that. So I think that, again, none of this none of this is unavoidable, and you can do things that help the absorptive capacity, but it's kind of like medicine. There's some medicine that you have to give, or vaccines with certain adjuvants. Now, there's no doubt that if the body was different, you wouldn't have to do that. If the body could absorb more, you just give it. But the point is, if you give a certain adjuvant, you increase the ability to give that medicine. Similarly, I think we need to give our aid with adjuvant therapy in fragile states, which will vary according to the country, but it's not impossible.
I can only say what I said before, and Emmanuel repeated, that if absorptive capacity is a problem, we need to solve it, not use it as an excuse for lowering our levels of assistance. And if it is a problem, then we need to help countries develop their capacity to absorb the funding. One way of doing that is to work, as Emmanuel said, at the systems level and let them do that. And another way that Emmanuel brought up is to allow donor funding to be used for recurrent costs. That would go a long way to helping them absorb capacity.
I'm Pat Effenpier with the Office of Democracy and Governance. And Liz, I had a question. You were saying that your organization is changing, which I think is really great to hear the ways that you're doing that. We've been understanding that's something that's happening in the whole development humanitarian community. What I was wondering, though, is if you could give us some specific examples of how those changes are taking place, like when you're looking at the long term as well as the short term when you go in, when you're trying to build communities and institutions, I guess at all levels, to try and create some cohesiveness. What are some specific things that are being done differently now?
Yeah, concretely, if we take probably in the last 4 or 5 years. We've probably been doing this systematic or slowly over the last 7, 8 years. But you'll see it more and more in programs. In terms of strategic planning in the country program, even when we start. Now within 3 or 6 months, they're starting to take much longer term views in strategic planning processes. In programming, if you look at the types of program we're doing, it's much more, in the past it was service delivery and direct implementation in service delivery. Now, there's been exceptions to the rule in every sector, but now systematically it's moving less to direct service delivery, or doing direct service delivery very quickly and getting off of it much faster and starting to move towards capacity building, whether that be civil society, whether that be governance, whether that be community. So you see that in almost every sector now. You also see kind of a little bit of a push towards not just community, but moving up and helping understand the linkages between community level, district level, and provincial levels. Because in a transitional setting or a post-conflict, you're putting systems back together from the top and from the bottom simultaneously, and you need to bring them together. And so you see that linkage start to happen over time, and we're starting to help foster that process. So that's kind of some of the, if that answers your question, some of the changes.
Sure, of course.
I don't want to respond directly to the question. I just wanted to say that I think that the three of us are all singing the same song, and I want to try to kind of encapsulate it a little bit. For one thing, I think that the health sector people and the democracy and governance people, as Liz pointed out, sometimes speak different languages to some extent. When I think, I I knew I was going to fall into the trap that I always reproach myself for, which is to use the term government on a lot of my slides rather than governance. But I think there are few sectors beside health that really put a premium on the relationship between government and citizens. And in some of our countries, the health systems, for traditional reasons, are really the strongest relics of what's left when a country is beginning to rebuild. Emmanuel said this. DRC is a prime example where it's really only the health system that continues to function well amongst all the others. Health systems are an extraordinary entry point for that reason in helping to develop governance. When you have a good health system, what should happen within that system is that citizens ought to be able to make claims on the government for services, and the government's obligation is to honor those claims. That whole process of being able to go to a health service run by or managed by a government, not having the services necessarily delivered by government, but that whole process of having people able to make claims, whether it's at the village level or at a higher level or even a tertiary care level, and having a government that's capable of fulfilling those claims, that for me is what governance and democracy is really about. And I just think that we ought to recognize that it's an obligation of the health system not only to improve the health status of the population, but to work in such a way that it fosters better comprehensive governance. And it's an obligation on the part of people interested in seeing improved democracy and governance to understand that a functioning, efficient health system is an extraordinarily good place within which to make that happen.
Right, and if I can, I'm
Oh,
sorry,
sure,
go ahead.
no, no.
I'm just to add to that, I mean, that is exactly the point on both sides. And the difficulty, I think, for all of us, or the challenge is, how do you start to get your staff trained up on both sides of that equation, or how do you bring in staff that are complementary to be able to facilitate both the governance aspects and the technical service delivery aspects, and how do you do that directly at field level and programming?
If I could ask a question about perhaps it's the specific example or your IRC experience in terms of dealing with militaries, and in some ways, because we have now a looser definition, shall we say, of post-conflict settings, militaries that are, for example, our own, and what are you finding that's useful? What are you finding that's difficult? What are the suggestions for how, as they are either willingly or unwillingly being put into the role of playing some of the roles in terms of provision of service that civilian agencies have played in the past? Are there changes? Is it something that's new? Are there things that could be done better, be done differently than how they are now?
Yeah, it's a really good question. I don't know that I'm the best person to answer it because I haven't studied it enough, and I haven't been to Iraq. I've only been to Afghanistan briefly, and I think that's really the two places where we see that actively happening. And my understanding and what I saw in Afghanistan at the time was that, the military definitely was involved in reconstruction efforts and what was traditionally humanitarian reconstruction efforts, but some of that was just very basic reconstruction, and they hadn't really begun to move on to this idea of capacity building and understanding the whole idea of institution building and the whole idea of community and how you reconstitute communities and all the importance of all of that. Now, how that impacts on how well the job gets done is the question, and also on the humanitarian sector and space. And maybe, Ron, you can answer more to that if you have a better sense from Afghanistan.
Yeah, it's a difficult problem. As Liz says, it doesn't occur in all that many countries. But in Afghanistan, there has been a lot of criticism from civil society of the PRTs. And one of the reasons, I think, is not that the military isn't making an effort to get the job done that oftentimes the humanitarian relief agencies can do, but it's a new business for them pretty much, and they don't have the experience, and they don't have the sophistication. They don't know what the traps are, and sometimes it's very easy for them to deal with people that they have to get the job done fairly quickly. So it's a question of who they deal with. They deal with people within the community who put themselves forward and who can speak English slickly, whereas that might not be the appropriate person or the appropriate group within a community with which to deal. So they get taken a lot, and I think they've fallen behind because a lot of the contracts that they've let out for the reconstruction of health clinics specifically, they've let to people who are out to get their money and not so much to do good within the community. So there's been a lot of, and it has a kind of ripple effect because they're getting ripped off. A lot of money is being squandered. A lot of the contracts aren't being honored. The materials turn up late. The work gets half done. And not only does it have a ripple effect in terms of the reputation that spills over to the humanitarian groups and the more experienced development groups, but the communities also get stuck with half-constructed clinics and half-constructed schools or promises that aren't honored. So I'm not saying that it can't be done or that it's inherently bad, but it's traditionally not the job of the military. And for that reason, unless they put a huge effort into learning that business and improving their performance, one has to have the feeling often that it might be best that they stay out of it.
Are those lessons perhaps parallel for the UN peacekeeping, whether it's DRC or Haiti or not involved in it at all?
No, I mean, the peacekeeping forces don't seem to do the reconstruction work or aren't kind of making that move yet. Their mandate's very clear.
We're about at the end of our time. Ritu, want to give us a final question?
Yeah, I'll give you a final question. Thank you so much, you guys. We definitely wanted a presentation where we wanted to know from you how to do health differently in fragile states, and that's exactly what we got. My question is, you brought up the relief to development transition, and you've taken the first step in sort of really taking the lead IRC has. What can we do on this side to help humanitarian NGOs link up with the development side? Besides linking up with OFDA on this end, what can we do to help you link up with the development NGOs?
With the development NGOs?
Or cooperating agencies, contractors?
Yeah, it's a really good question. I have to give more thought, but that is exactly what we need to do, is figure out mechanisms, whether that be through forums, whether that be through actually, even in programming at field level. I mean, if you think about RFAs coming out and consortia coming together and partnering with those that have the development skills and us having the conflict skills, and that will be a learning curve as well, because we talk different languages sometimes, but we have to come in at the middle to the same. But that kind of thing, the more we sit together in rooms and do training, quite frankly, is the way we're starting to learn from each other. Yeah.
I have to say, I'm beginning to wonder whether that distinction is real, because on both sides, if you look at what IRC does, I mean, it's a dirty word on our side, but really a lot of it is development. And both what happens in population-based settings rather than camps, which is a lot of where we work in, and as Ron said, we're there an average of close to 10 years. And so in a lot of the settings, you end up really doing development more and more consciously, but we've been doing it for a while. Even in camps, if you look at what was going on in the camps with Sierra Leonean refugees, now we work with them now that they've returned, you realize a lot of development did go on in those camps at the person level. So on that scale, I mean, I think in many ways we do development. I mean, we don't always do it as well as we could, but that's true, I think, generally of NGOs, that there's more we could be doing, but we really do a lot of development. Conversely, I can't think of a lot of NGOs, quote-unquote development NGOs, that aren't involved in relief. I mean, CARE, Save the Children, World Relief, Concern Worldwide. I mean, all of them have fairly substantial emergency or relief operations, and they're all, like in Congo, we see, the usual suspects, and they face the same issues. I think where we add value is maybe by having some of the specific post-conflict thinking, but all the agencies are facing these issues, and we work together.
Right. I was thinking more of like the global health development agencies, like Measure Evaluation has indicators. You know, they have indicators from A to Z, and so you're looking for indicators.
Right.
So
Right.
that type of relationship.
I think practically speaking, you're in a very good position to make that happen because you can put conditions into any of your RFAs, and they're not going to shy away from them. They're going to meet the conditions. They want
And
your
invite
money.
us to those meetings.
But so that's
Yeah.
quite important. And
And
the
I
other,
think-
go ahead, man.
Yeah, there's just a quick thing. The core group in the CSTS, the whole child survival world, for us has been a great way because it's basically been a way to expose us to more development world. So I think part of the answer is those kind of mechanisms of bringing people together, because the RFAs as they are allow us to collaborate, and there's a lot of opportunity. But the more we meet, obviously, the more it's going to happen. So I think child survival and the way USAID, the Child Survival and Health Grants Program, has organized itself, I think, has a lot of lessons because it's really helped us integrate more and do, now we have grants with World Relief, with SAVE and all that we've gotten through those fora.
It's important to bring that coordination about, but I don't want to let the discussion end by on this point of trying to forge better coordination amongst the NGOs. I think it's really important to understand that, especially in that transition and post-transition period from emergency to development, that NGOs find themselves in competition with governments for resources and for areas of work. And that's the really serious conflict that develops. And that's why I used the word carefully before when I said that I think NGOs ought to subjugate themselves to the authority of governments. That's something that doesn't happen very often, and the donors frequently contribute to the tensions that arise between governments and NGOs in the way they place their money and the ways by which they place their money. So there's that triad of donor, recipient, state recipient, and NGO that needs to be carefully studied, and the arrows and links and relationships between them need to be analyzed and played out quite carefully. That's a very dangerous area in a post-conflict period in a lot of countries, and many situations have come to no good end because that relationship hasn't been managed well.
Well, that's a good way to end because it gives us a sense that there's still lots of work to do and figure it out. I mean, there was no doubt about that by any of the presentations, but no, I think that's one that has been a question and attention that's come up in discussions before. So it's terrific that you've kind of reiterated the importance of that point. Well, thank you all very much. We got an awful lot of terrific work on the table for us. And I think you really did us a service by coming and making this presentation. So please join me in thanking our guests. Thank you. Thank you.
When we tried to have the idea that we give like 15% of